I'm Herschel Patel. I'm the head and neck fellow this year. So I'll be here from July to July, and I will meet a lot of you guys very soon on the floor if I haven't already. And so then today's talk is going to be hemodynamic monitoring following head and neck surgery. So, what the significance of this, head and neck cancer patients have risk factors that are common to both cardiopulmonary events and the cancer itself, tobacco, alcohol use. They're usually higher in age and they're very frail. So those are your typical head and neck cancer patients who are requiring surgery. So at baseline, they are already ticking the boxes for high-risk patients on the floor in general. And then you add cancer on top of that. And then the unique thing about the head and neck cancer population is post-operatively or intraoperatively, we perform microvascular free flaps. And with these patients who are at risk for cardiopulmonary events, we are trying to do our due diligence and monitor tissue perfusion as best we can. So historically, after big flaps, these patients were taken to the ICU and monitored in the ICU because they require unique things like every hour check of the Doppler, making sure that somebody's laying eyes on this. And previously, this was not thought to be able to be done on the floor. And around the mid-2010s, the question started being asked, do these patients need to go to the ICU or can they go to a non-ICU floor? And what's the difference in care? And so a study that was performed here or with the head and neck group here showed that, there really wasn't any difference in safety. But what they saw is patients who did not need the ICU had reduced costs because they weren't staying in the ICU, but also had a shorter hospitalization, which again will reduce costs. So the question continued to be asked whether ICU versus non-ICU care was appropriate for these head and neck microvascular free flap patients. And a larger systematic review that included this study showed that there were comparable safety for free flap reconstruction that went to the non-ICU, so basically the floor telemetry versus the ICU. And so in this paper was published as recent as 2022. So this is not something that people have been exclusively doing for years and years and years. It's fairly new that people are, going to the floor now and they have comparable outcomes and safety. And so another principle of how you manage these flaps, so traditionally, the goal was to keep the blood pressure at a certain amount. So the MAP greater than 65, have normotensive, and then urine output, which is, normal standard urine output for an adult is 0.5 mLs per kilo per hour. In this way, patients may get a little bit more fluid to keep up with this urine output if needed. And fluid was really what was driving keeping these patients normotensive and MAPs greater than 65. And then there's a more goal-directed therapy. So, or if you say a fluid neutral, so you're measuring in-hospital weight. In-hospital weight can be a lot of correlation with how much fluid they've gotten over their hospital stay, but also with the stroke volume variation. So the SVV, which my previous institution we called the non-invasive arterial monitor, the flow track. I'm not 100% sure what the technology they use here, but the SVV is part of the cardiac modalities, which basically measures your variance in your stroke volume, so how much your heart is pumping, with respiratory contributions. So when we take a deep breath, the stroke volume usually goes down as there's more thoracic pressure. And on traditional art lines, you can see that just by looking at the waveforms, and you see that go down and up. And the SVV on these non-invasive arterial monitors will just kind of quantify that in a number form. And so to do that, you do need more of a specialized monitor to be able to gain that information. And so, when they looked at this, whether it was standard fluid therapy or the new goal-directed therapy, they found both were acceptable. Both had similar rates of mechanical ventilation, or no difference, I should say. But what they did see is that in the goal-directed therapy, there was a longer hospital stay and shorter duration of oxygen demand. And some of that may have been, oxygen demand, if you're giving less fluid over that course and you're giving a more goal-directed, you can postulate that less fluid on the lungs makes oxygen demand go down. But then also they had the caveat of having a longer hospital stay, which increases cost. And so what they found intraoperatively is the goal-directed therapy. So there's kind of a flow chart here of how they would use that intraoperatively. So if they had hypotension, they would look at this SVV number versus the cardiac index. And cardiac index is just your stroke volume times your heart rate and the patient's BMI. So it kind of gives an individualized cardiac output based on the patient's height and weight. So they would look at these two things. And so we talked about the SVV. If that was greater than 13, meaning there was lots of variance, likely meaning they were down on fluid, you'd give a fluid bolus and reassess. And if the index was low, if the variance was normal, but the index was low, then you would start pressor. And if systemic vascular resistance, you'd start an additional pressor and reassess. And then on the converse side, if the patient was hypotensive, but their MAPs weren't low, then they would look at the cardiac index and potentially start a dobutamine trip for cardiac specific ionotropic effects. Okay. So what they found was, in all three of these limbs, there's an avenue for pressors. So for vasopressors, and for our free flaps, we're hooking together small arteries, and there's small blood vessels in the actual flap that are very sensitive to constriction, and vasopressors essentially constrict these arteries and can cause flap compromise. So this goal-directed therapy intraoperatively is controversial. And, if a patient does need pressor and it's, there's pressor or, fluid's not working, then yes, they need that, but always let we'll have anesthesia, let the surgical team know. And if ever on the floor they need pressor, obviously the surgical team needs to know. And so what they did see on the converse side after they left the OR for goal-directed therapy is they had shorter ICU length of stay and ventilator days. So, the controversy of this is there's greater flap compromise with vasopressors intraoperatively, but once they hit the floor, they've had less fluid. They're optimized from a fluid standpoint, and they're not hypervolemic, they're more euvolemic, so they have shorter ICU stays and they come off the ventilator faster. So again, it's a balancing act between flap compromise and patient benefits in a global standpoint. So how are we monitoring? So there's tissue oxygen monitoring. So the SVV I talked about. So these numbers you see in the corner over here, again, we used to call this a flow track, but basically it's a non-invasive arterial monitor. So usually an art line is hooked up to the monitor, and it tells you where we're at. So cardiac index, and they even give you a range, and there's green and there's red. And so it seems very intuitive and user-friendly. But there's caveats to this as well. A patient in AFib will not have accurate non-invasive cardiac monitoring. And many of our patients, like we talked about, are elderly. They go into AFib here and there. So any irregular heart rhythm will kind of not make the flow track monitoring as useful, or the non-invasive monitoring as useful. So there's problems with that in itself. Central lines, you can measure the CVP, so the central venous pressure, to see, how much fluid you have. Are you low? Are you high? But central lines in themselves we can't keep them in for forever, because they're an infection risk as well. And then there's also these infrared monitors that analyze the tissue, but there's unclear benefit. There's unclear data to support benefit versus that or traditional monitoring. And so, what do you guys need to be looking for? What do we look for when we're on rounds? We look for flaps being warm. A flap that's cold is something that needs to be investigated further. Pink, or sometimes they can be white, but generally they will still have capillary refill, so you can indent it and you can see cap refill. We do a lot of pin pricking when we're on round, so we'll take one of those diabetic needles, prick, and slowly come out. And what you should really want to see is a slow, bright red ooze, rather than fast ooze or dark ooze, or a combination of both. Because essentially, if you see this diagram here and up above, so this is the flap that's harvested from various locations on the body, but this looks like a forearm, or sorry, that's a fibula. So that's bone right there, and then that's the skin paddle, and it's supplied by a perforator. And so there's usually at least one one artery and at least one vein that supply it. And if you can see up in the top left, you can see the artery being anastomosed, so reconnected with suture, and the vein here also coupled together, and you can see Dopplers on them. And so these are the Cook Doppler leads. And so as this pulsates, it gives us a audio signal of what that sounds like based on ultrasound. And the vein does that as well. And there's actually two clips that I hope work of what those should sound like coming up. But so the pedicle, which is the artery and the vein, come in like that. There's the connection, and then they go to all the capillaries. And so any issues with venous backflow, venous flow, so leaving the flap, which is the most common reason flaps go down, it will cause a more high pressure ooze that is darker, and the flap will look more congested. Temperature probes, they can be used, but it's less of a kind of concrete way of monitoring. And then we also talked about tissue oxygenation monitoring. But clinical exam in itself can be very helpful in just knowing what a flap should look like, what it will look like. And lots of people, or lots of you guys who will be working on 6 will see these flaps, and over time we'll get to know when the flap looks congested, when it looks healthy. But this is kind of what goes into setting up the flap for success. And so if there is ever an issue with a flap, we need to know early. And so the first 24 to 48 hours is when early failures can be salvaged. So we take them back to the OR, we see what's going on. Again, lots of times it's venous issues, sometimes it can be the artery too. But the key is early take back and vigilance on the floor to be able to call the the next level up to say, hey, this doesn't look right. Can somebody come take a look at this? And I'm hoping these play. Well, I think a little bit was lost in translation with emailing this to myself, but unfortunately I don't have that. But I'll be on the floor a lot, and if you guys ever have questions on what a normal arterial Doppler or venous Doppler should sound like, I'm more than happy to come up and let you guys know. So here are just some flaps that were done in the past. And so the top one, it's pink, it's healthy. It's a pretty large flap, and you can see here there's 2 Doppler leads. So these are the Cook Doppler leads, and you have these silver wires. And so the silver wires connect the actual latex or plastic deal that encircles the artery and vein. So those, we try to set it up in a way where they don't get pulled out too early so that we have constant monitoring. Another flap, as you can see on the leg, that started off nice and pink, but then it got congested like this. And so that congestion is a big sign that we need to go back and figure out what's going on and see if we can salvage this. Because the congestion of the flap basically does not let arterial inflow happen because there's just so much pressure kind of in the retrograde fashion. So now, a lot of surgery teams have enhanced recovery pathways, colorectal, head and neck, even bariatrics now. And so, lots of different things are on the enhanced recovery, but what are the most important things and what show the strongest evidence and have the strongest correlation to success? And so you can see, there's preoperative nutritional management, there's prophylaxis against VTE, which is very important, and specifically in the head and neck, patients and teams that had high compliance of preoperative fluid management, not needing to go to the ICU post-operatively as much, good pain management, multimodal, post-op flap monitoring, at least 24 hours. We do 72, but at least for the first 24 hours. And then mobilization. Again, these patients are frail. They start off at a baseline that is probably not the most robust. And so these patients, to keep them from getting debilitated, early mobilization and keeping their strength is key. Post-op wound care. So lots of times we have wound vacs, we have bolsters, and the flap itself is included in wound care. And then Foley catheters. We know those cause UTIs. And so, but they're essential for the first 24 hours to make sure the patients are making good urine. But as soon as we're, out of the woods in that first 24-hour period, we should be looking to DC the Foleys. So in the mornings, we usually come around, and if we haven't taken out the Foley or mentioned that, then we need to, we sometimes need to be reminded that, hey, this patient still has a Foley. Do we want to keep it in or not? And so high compliance of these components also kind of tie into hemodynamic monitoring. And so on a bigger study that reviewed the literature and performed meta-analysis on it of patients or groups that use the ERAS protocol in head and neck cancer, showed that high compliances with those specific ERAS recommendations actually led to reduced hospital stay. And so reduced hospital stay, keeps the patient from being in the hospital longer, obviously, but what does that actually mean? Every day the patient is in the hospital, they are not independent enough on their own. And so there's chances of more debilitation, there's chances of picking up more infection. So getting them out of the hospital is key for the patient, but also for the healthcare system as well, where it reduces costs in general for the system. And so what the take-home points that I hope you guys get from this presentation is these patients are susceptible to hemodynamic instability because of all the factors we talked about, but cardiovascular disease and these patients go hand in hand. And these patients not going to the ICU is actually very safe. And I'm sure there was a big push against this early on because it can be scary having these big reconstructions come to the floor, but over time it's seen that it's actually very safe. And here we do a more traditional free flap monitoring on the floor, but goal-directed therapy is also appropriate. And if you ever see us using that, then we can talk further about that. But we are ourselves don't use the SVV monitoring on the floor very much, and go with more of a traditional approach, and both have been acceptable. And then there's unclear benefit to using the flow track or the non-invasive monitoring. And going back early with these flaps is critical to success if it goes down. And so being vigilant and letting us know if there's any issues and being comfortable knowing when there is an issue is extremely important. So thank you guys for having me. I'm excited to see you guys all on the floor in the hospital, and look forward to working with you guys.
Good morning. My name's Jamie. I'm one of the dietitians here at the hospital. My main purpose of wanting to do this is just to kind of give you all a little bit more of an insight of what we look at when we see patients, plus the difference between what inpatient dietitians do and what outpatient dietitians do, just to kind of give you a little bit more perspective of how we, what our role is in the overall care. So the learning objectives that I have here is how we assess patients in identifying malnutrition, because malnutrition in head and neck cancer patients, as you're all aware, is pretty high. And I will be honest with you, I've been here about 8 years, and I probably didn't have a great understanding of what that truly meant until the past few years. Just for the simple fact that, sorry, my allergies. Just for the simple fact that we're wanting to streamline how we take care of our patients. And then I'll talk a little bit more about critical weight loss and the benefits of proactive versus reactive feeding tubes. And pretty much that's it. So, problem. So again, you're probably all aware, head and neck cancer is on the rise, and over 80% of the head and neck cancer patients are treated with either radiation or a combination of surgery and chemoradiation. So this statistic of 2.5 per year with men and 0.5 per year among women, to put it in a perspective, if you're anything like me, it's about 54,000, I would say over that per year of new cases. So to me, if I look at these numbers, I'm like, oh, that's not so bad. But when you look at the reports and that's the amount of new cases each year, that's pretty significant. So I'm going to talk a little bit more in depth about how we evaluate patients. And of course, the main thing that we look at is PO intake. So again, I bring back the fact that with inpatient dietitians versus outpatient, it's very different in the sense of, in the hospital, it's a more controlled environment. So you're able to control how much they eat, making sure they take their medicine, making sure that they're tube feeding, that they're doing what they can. So then obviously when they leave the hospital, a lot of things may fall to the wayside. So how I would say a lot of the patients that we see are typically men and small town, and that they have jobs where it's farming to truck driving. There's quite a wide range. So we really do, I can't emphasize enough that we really try to hone in on what is realistic for them. Body weight is going to be another one that I'll talk a little bit more in depth about. And I wanted to emphasize that it's really more about their normal weight and not about ideal body weight. So to be honest with you, the BMI is not my favorite, but it is a reference that we use. So it's one of those factors we take into consideration. But I would say that when you are a male, again, small town, and the average weight is anywhere between 200 and 250, and they're about to go through cancer treatment, and they've never thought about how they eat for their entire life. And so trying to get their buy-in is huge. So trying to get them to like you is very important. So if we don't have the opportunity to build that rapport, and they've been heavy most of their life, and all of a sudden here I or one of my peers walks in the door and says, "Hi, I'm the dietitian and I'm here to help you," they don't get too excited, let's put it that way. So again, we want to be as realistic about things as possible. So with that, the physical examination, and I'm sure that a lot of you have probably heard of the nutrition focus assessment, where we basically look at signs for malnutrition. So with that being said, it is ideal if we can do that on a lot of patients. But in our world, so to speak, sometimes we have 5 minutes with the patient, or up to an hour. And it really kind of varies because how we see patients, we may see them after their doctor's appointment, or if they're going through chemo, so we have a little bit more time. Radiation is a quick visit. So the amount of time we're allowed to spend with patients really does vary. And so we may have the opportunity to look at all this information with their labs, their medical history, and we may not. So we may end up having to rely on what they tell us as well. So yes, with labs, and so quality of life, and I can't emphasize enough how much we try to hone in on this, because willingness to eat, because imagine that if you have ever had COVID, if you ever had the flu and you're feeling miserable, and here I walk in and say, "No, you have to eat." And it's just not appealing. Because again, with the approach, if I walk in and say, "You have to do X, Y, and Z," I know me personally, I would want to do the complete opposite. So it's really the art of trying to get them to do what you feel like they should do, ideally. But that's huge, the ability to eat, and we'll talk more about that, and a lot gastrointestinal issues. I see this more and more each time I talk to people, that if they have any GI issues prior to getting treatment, they're going to struggle a lot, I would say. So this here kind of gives you an idea of what goes on with what people struggle with. So a lot of it is if they end up doing chemo and radiation as well. And cisplatin is one of the chemo drugs that they're on, which you're probably aware. That is a pretty brutal drug on top of radiation. So they start to have all these issues. And I would say that dysphagia is huge. That would be a big one. And taste is huge. They all play a role, but I would say those two are probably the more common ones that they struggle with. So again, so when it comes to critical weight loss, again, when we talk about weight and you think, okay, if a male is 250 pounds and if they lose weight, well, they can afford to lose weight. Well, studies have shown that if people, regardless of whether you feel that they can get away with it or not, it decreases their quality of life. It absolutely decreases their quality of life. And again, back to the focus assessment, I've done this where obviously with certain patients, you are able to pick up on the signs a lot faster than others. But in my opinion, and I can't speak for my peers, is the fact that I feel like when you look at their eyes, they all have the same look. They all have the same look of when they're about to crash. And what I mean by that is they're losing weight, and then all of a sudden, the moment they lose a significant amount of weight in 1 week, they have this glazed look over their eyes. They struggle with focusing. And on top of that, they're having to remember to take all these medications, to treatments, to doctor visits. And ideally, as we all know, support is great. We've had people that go through treatment that are alone, which is pretty tough. And it amazes me when you're motivated, what you're able to do. So with that being said, the critical weight loss, it is defined as greater than 5%. And this is more for a month. I'm sorry, I don't know why that's an error. So in a month, 7.5 is in 3 months, and then 10% is within 6 months. And so when they go down this rabbit hole, it's that much harder for them to get back to their norm. One of the things that I hear people say is, they want to know what foods to avoid or what foods that are going to be able to benefit them in the long run, which I think is great. And I don't want to discourage people by any stretch of the means on how they eat. But again, thinking of, okay, is this the right time to be having this conversation? When you have all these side effects, you're not going to be open to eating quinoa or spinach because you're struggling and you're dropping weight. And if you aren't focusing on a high calorie, high protein diet, you're going to keep losing weight. So I would say a lot of people focus a lot on protein, which protein is great. Protein they absolutely need. But if they're not getting enough calories, it's really not benefiting them. So these are the things that we look at. And being able to, I don't want to repeat myself. So consider appetite stimulant. And that is, so again, I really base it off of where the patient is at. And I do bring up appetite stimulants depending on the patient and if they're open to it. Because again, if they're taking multiple medications, the last thing that they might want to do is add another one on top of that. And we do ask, if they're having nausea and if they're throwing up. So are they on the right agents? So anti-inflammatory agents for that. Or even if they're having diarrhea or constipation, if they're taking their stool softener. And if it's something where they want to consider an appetite stimulant or something else, I personally defer back to the doctor, because that's just me. And so if I know it's something that the doctors are okay with me saying, then I do. But if not, I just defer it back to them. So when it comes to feeding tubes, that's kind of the big project that we are trying to streamline, which I did not realize how big of a project that was until we started it. And the challenge is obviously it's really hard to predict how well people go through treatment. I will tell you, I've had people that are very healthy, young, strong, and you think they're going to do great. Halfway into treatment, they crash and that they need to get a feeding tube. And the other extreme where I've had people where I think they are extremely malnourished. And they need a tube ahead of time. And that I feel like that's the best option for them. They refuse and they do fine. But I would say those are probably two extremes, because for the most part, what we're hoping to do anyways is try to figure out a better way to potentially predict those that need it and those that may not. And again, so quality of life is what we look at. So based on the definition, so if anybody's food intake is less than 60%, usually I would argue that anytime that they are starting to struggle, again, it's kind of an overall based on the dietitian, what we think, I would say. But that's part of the reason why when we first meet with patients, that's the ideal time. Because when we meet them from the beginning, we build a relationship, we build the trust. Plus, we have a better prediction, so to speak, of how they are, personality, what their ability is to do things, their willingness to be open to our recommendations. Again, what is their norm? Because if their norm is, oh, I only eat 2 meals a day because I don't have time, and then all of a sudden you're forcing them to eat more than they need to or they want to, it's just this constant back and forth of what you feel that they should do, but what they're open to do. So yes, if they're eating less than 50%, absolutely, it's a concern. Ideally, to be able to figure out what their norm is, but like you and I, we all kind of eat a little bit different every day. So you are all aware of the different types of tube feeds, but the most common that we do over here at the Cancer Center is the bolus feeds. So I would say most patients that end up getting a feeding tube, most of them, we try to do bolus feeds. But a lot of the patients that struggle and have GI issues, then we might end up having to put them on a pump. But with insurance, you are all aware how great insurance is. Haha. And sometimes they have to fail on a bolus before they're allowed to do a pump. Or the fact that certain formulas they aren't allowed to be on until they do a standard. And right now, with the formula shortage, that brings us to figuring out how are we going to be more creative in getting their calories and protein needs in with certain patients. Or the fact that the cost in general, you all know that it's on the rise. And so the fact that some people, when you go through treatment, it's expensive. And what we try to do is to help kind of offset some of that cost, even though it's probably very small in comparison, but it's absolutely unbelievable how much things cost these days. And I'm sure you guys can agree with that. Sometimes, you think that a patient really should get a tube, but based on the location, excuse me, of their cancer as well, it might not be the best option. So the benefits and disadvantages. So the benefits of them not losing weight, they have fewer hospital stays, improving their quality of life. and that it may help them get through treatment. Because when they're not doing good, they struggle with eating, they lack the motivation. And I would say my point in all this is that, if somebody's motivated enough, they can get through. But my concern as well is what their quality of life would be like in doing all this. So yes, I can't emphasize enough, it really depends on the patient, excuse me. And what they're able to do. So what we try to do here at the Cancer Center is while they're going through treatment, we see them at least once a week. Sometimes we see them more. And it's really based on the fact that what their needs are. If there's any concerns, because not only do the doctors refer patients to us, but also staff as well. And I would say on average, once they start treatment, we do a pretty good job in seeing them at least once a week, and some more, when it comes to this. And yes, cost, like I said, we try our best to kind of help alleviate some of that cost when people are on feeding tubes. Risk of infection, it does happen, but I don't think, based on the ones that we've seen, I don't think that it's as bad as, don't get me wrong, we have ones where they do have their challenges, but I would say for the most part that it's pretty manageable. And in my opinion anyways, if we, the dietitians, take a big role in helping the patients get on the tube, their chances of getting off the tube is a lot higher as well in doing that. So I just kind of wanted to end with just kind of giving you some examples of patients that, just to give you an idea of some of the challenges that we go through. So when, again, if a male patient comes in, and he's told that he's going to lose a lot of weight, and he was about 250 pounds. And because all he heard was the fact that he's going to lose weight and that he's going to have to struggle. So some patients, what they end up doing is, well, then I'm just going to eat all I want. I'm just going to go crazy. And this one that I'm talking about was a little extreme. He ended up gaining 20 pounds before he started treatment. And I would say that losing 20 pounds during treatment or gaining 20 pounds, neither one is ideal. And that those are things that you should avoid. Because again, yes, we don't want patients to lose weight, but we don't necessarily want them to gain that much weight either. And that's what he ended up doing, because he thought that would offset his side effects, which actually it didn't. He started to drop weight quite a bit, and he ended up getting a reactive feeding tube. And he got used to having the feeding tube, because when you feel like crap, you finally get a feeding tube, you feel better, it's more convenient. He was kind of like, so why do I need to get off of it? But with the help of one of our speech therapists, I will say that he no longer uses it. But again, my concern is that the significant weight gain and the significant weight loss, and how is that going to impact him in the future? Another one would be a female that I am working with, very thin, completely opposite. And she was struggling with diarrhea, and she's been struggling with that for a very long time, regardless of the different formulas, regardless of medications, and she really can't afford to lose any weight. But I had mentioned to her from the beginning that I really think you need a pump, because of the challenges that you're having during treatment, because of your medical history. That's the only way your body's going to be able to handle it. But then she did her own research, and she's like, well, I want to try this formula, or I want to try this supplement to be able to offset it. And there's only so much we can do. And I'm sure you've all had that experience as well. This is what you're recommending. And the patient's like, nope, I want to do this. So sometimes it's a matter of, well, they're going to do it anyway. So I still monitor them. And then now she's at the point where she's like, okay, I'm open to a pump. But it took a long time. It took a long time to get her to get there as well. She has my trust. She always asks me my opinion, but she wasn't ready to be on a pump. So no different. I'm sure you all have that experience as well with some of, because you work in healthcare. And here is all my references as well. And there's a lot more, I would say, out there. But probably the big one that we tell patients would be the American Institute for Cancer Research, because they do a lot with nutrition and cancer when it comes to different types. So not just head and neck, but gyne to lung to, it's very user friendly. I really do like that quite a bit. Aspen for the 2 feeds, you're probably aware that that's a big one that we use. And for our education that we provide to patients, it's the oncology nutrition dietetic practice group where we get a lot of our education materials. So that is it. Does anybody have any questions? What are some determining factors as to why a patient would receive a PEG versus a DAPA? So versus an NG tube, what would you say is more common? In your experience, do you feel like patients do better with one versus the other? So I would say that a PEG tube is definitely more common. With a DAPA, in my opinion, I'm really not a big fan, because I know with nursing, you guys are the ones that have to place it. The benefit to that is obviously it's quick, but it's short term. And it's kind of, I mean, it's inconvenience in the sense of, you know, you have a tube stuck down your nose and being able to, you know, imagine having that and you got to go to work. Or the challenge with having a DAPA and being a farmer. Not to say it doesn't happen, but if the doctor feels like it's just a temporary thing just to get them through this hump, that's kind of why they do it. So with PEG tubes, and especially with insurance, ideally, you know, they want, I would say 3 months would be the bare minimum. But, you know, what we're coming to find again is we're really trying our best to streamline this process. And in my opinion, based on my own personal research, that the critical weight loss doesn't stop during treatment. It's actually pretty significant post-treatment as well. And that even a week after, I don't know what it is, but people that do what we ask to people that don't, they can easily drop 5 to 10 pounds. So in my opinion, you know, I do prefer them being on a PEG. So there's also different variations as well that you're probably aware of, like a Mickey button, but they have to have the stoma and in place before they transfer to a Mickey button. I'm just going to read what Dr. Panwar wrote, is that PEG longer term needs surgery, more comfortable, NG short term, bedside insertion uncomfortable. So the nutritional outcomes are not substantially different. So that's what Dr. Panwar said, you know, and I would just say that really a lot too is that what is realistic for the patient. And so me personally, if I was to have either, I definitely would want a PEG tube, just for the simple fact that you can cover it up and people have no idea that you have it. And that's what I tell people. And, you know, I tell a lot of my patients, my goal is to help you avoid being admitted to the hospital. That's kind of how I put it. And I tell them, I say, I really do think that this is what's going to help you, and that we still want you to eat and drink. The point of you going through treatment is that you're able to do that once you're done. And so this is just something to help you through the process.